Welcome to the Stratis Health Behavioral Health Initiative meeting. At this time, all lines are open and interactive. We ask that you please keep all side conversation and background noise to a minimum. If you are not speaking, please mute and unmute your line by pressing *6 or by using the mute button on your phone. We also ask that you do not place your line on hold, as music will interrupt the conference. I will now turn the call over to Nicole Gadsdetter. You may begin.
Great. Well, good afternoon, everybody. This is Jane Gendron and from Stratis Health, and we'll get started in just a minute. We've got a number of people that are signed in. Actually, maybe what I'll do to get started is we're not going to do individual attendance, but it would be helpful to just have a general sense of which organizations are being represented on today's call. So I'm going to go through the list now, assuming that many of you are on the call, and then we'll get started. So, Alina, is anybody on the call from Alina?
Yes.
Great, thank you. Appleton?
Yes.
Great. Avera? Okay. Catholic Health Initiative? CentraCare?
Thank you.
Fairview? Hennepin County Medical Center?
Yes.
Okay. Hutchinson Health? ICSI?
St. here from ICSI.
Hi, thank you.
Hi.
Lakewood? Mankato?
Gabby Anderson's here.
Great. Mayo?
Yes.
Great. North Memorial Healthcare?
Yes.
Northfield? Ortonville?
Yes, Ortonville.
Okay. Keith River Falls?
Yes.
Okay. Sleepy Eye? Okay. I don't know if anybody else has joined. Maybe we'll get started, and towards the end we'll go back and see if anybody added call us. But good afternoon. This is Jane Gendron, and I'm the lead program manager for the Behavioral Health Initiative. I have with me today Laura Grandgard-Johnson, who is our research analyst, and the two of us will be doing this together. Laura will be specifically working through on some of the measurement pieces. But I'm guessing or hoping that all of you received the agenda, and we'll go through just real quickly what we're intending to do this afternoon. We've started with welcome and introductions, and then the first order of business is to look at all of the participants at the time that they enrolled earlier this year had filled out an assessment form. And Joe Galitis and myself have had follow-up phone calls with each of you to understand in a more detailed way what's the level of screening that's currently in place in your clinic, how referrals are happening, how assessment is happening. And before we get too far into the initiative, we wanted to be able to provide some feedback back to you about, in aggregate, what we were hearing from all of you. We also want to talk about some of the measurement pieces to this. As with every improvement effort, we always need to have a way of how are we going to demonstrate to both ourselves and others that we're actually making a difference. And so we've got some options about how we go about doing that measurement, and wanted to talk through that with you today. One of the proposed ways that we have is that we've created a draft of a alternative to the way that CMS has set that up, and Laura has been working on that and having that reviewed by others, and we want to get your feedback on that as well. And then finally, we'll wrap up by looking at, after we've gone through all of this, what do we think is the right areas that we should be focusing on next, and how do we go about doing that work together? So we've got a proposal that's in the slide deck looking at a cadence for meetings and webinars and just basically want to walk that through with you and get your feedback onto, is that the right amount of support, or if there are other things that you're looking for from us. So we've got about an hour and a half ahead of us, and hoping that we can get through this and adjourn on time at 1:45. And all of the lines are open, so let me just ask if anybody has any specific questions or additions that you want to make sure that we address today. Okay. Well, Nicole, let's go to the next slide where we look at the participants by organization. And wanted to make sure all of you are familiar and aware of who we're all are going to be part of this initiative. You're probably aware of the fact that there are two components to this, both an ambulatory clinic component as well as an inpatient hospital component. And what's listed on here, you may see that there are some that are listed as IPF, which is inpatient psychiatric facilities, which is a specific designation that CMS has for us to be reporting on, as well as there are some hospitals that aren't formal IPFs, but they are also participating. So we've clustered this into organizational size, not by any great magic, but merely as a way, as we were looking at the data about how assessments, about how current processes are going, as a way to help support if there are different ways that we could approach this based on clinic size or system size. And I think we did see in some cases that there are some differences based on the resources internal to an organization. So this is the list of participants and broken down by clinics and hospitals. Okay, next slide. As we were doing the assessment calls earlier this year, one of the things that we started with was CMS has some very specific goals for this initiative, and I know we've talked about those before, and we'll touch on those again today. But one of the things that we wanted to understand from each of you is, what are the drivers that you have for why you're participating in this? And I think we heard some interesting things, and we wanted to summarize that for you as well. Quite a few clinics were very mindful of the Minnesota Community Measurement publicly reported measures around depression. And even though they are somewhat different than, or actually differently focused than what we are working on, because they are oriented towards patients who have a depression diagnosis, there are still interactions that we have between the measures that we're working on in terms of increased screening that will impact in some way the community measurement measures. And so just being mindful of that and wanting to know that what we're doing is actually going to have a positive impact on the community measurement reported measures. A key driver, and we heard this from quite a few sites, has to do with the way that you use the EMR technology. We were asking about whether or not people currently have the capability in your EMR to trigger and identify patients who need additional screens. If you're able to have a way to track the depression screens or the alcohol use screens in your EMR for reporting purposes. And that's one of the things that we heard is really a main driver from many sites, where if we could maximize the use of the EMR technology, that would be a true gain for several sites. And I can say that we're finding that the software that's used is primarily in this group of providers. I would say at least 80% of them are using Epic, but we've got at least 3 that are using Meditac and at least 2 or 3 that are using Healthland, and 1 or 2 that are using Allscripts. So they do cluster fairly nicely, and I think that is something that will be important in our use as we go forward. The next area that we heard about is really looking at the technical issues around coding and billing. The CMS identified the need for this initiative through claims that are submitted through Part B, and what I would say based on our discussions is that it's clear that there's a lot more screening that's going on than billing. And as we talked to each of you, one of the things that we heard was that there is an ambiguity about the criteria that we need and what codes we use and how we go about that. So that's one of the areas. We've clustered a number of things into the clinical support area, and primarily it's identifying issues that are not around processes and technology, but more around physician and clinic engagement. So things like, how do we make sure that we're clearly articulating the rationale for screening? And while that is fairly well, there's a fair amount of consensus on that on the depression side, we heard that there is a need to articulate that in a more clear way for the substance abuse. Also looking at how we address mental health issues within primary care, looking at care transitions, particularly patients who go from the inpatient to the community, and then substance abuse, follow-up, and medication adjustments. And lastly, we heard that there is a fair need for having access to referral resources. There are some systems that have a fairly robust process and others that there are some real concerns about having access to referrals at the time that they're needed. So I'm going to stop there. The lines are open, and just ask the question. We may have captured the main drivers, but if there are other drivers that people on the call think that they have for participating in this initiative that you think would be helpful for us to be aware of, just wanted to give you an opportunity to state that. Okay, well, hearing none, we'll have another opportunity, but just as I said, wanted to give you the opportunity. Let's move forward into what we heard as we were doing the discussions with each of the providers. So one of the major areas that we were looking at is what is the current landscape in terms of screening practices? And we were talking about both depression and substance abuse. As we look at depression, I think primarily due to the many efforts that have gone on in Minnesota, Community Measurement, Diamond, Impact, there's been a number of initiatives that have gone on around depression screening that a fair majority of you have a fairly structured process for how you integrate depression screening into the process of care within your clinic. It was mostly focused around patients who present for preventive exams and people who have a previous diagnosis of depression. So it isn't across the board for all visits, but it is fairly well ensconced into practice for patients that are at preventive or wellness visits. The balance of the clinics screen some patients and have some level of depression screening. Everybody has something, but didn't have quite as formal a process. There was some variation there. But as we talked about the alcohol use, there are far fewer systems that have similar processes for how they do substance abuse screening. Go on to the next. So assessment and referral protocols. So in most cases, after a patient has gone through the screening, we were asking about, so what happens next? How is it decided? What additional assessment is needed as part of the diagnosis, and how do patients get triggered for any further care? And in most cases, what we were hearing is that the decisions about follow-up steps were really driven by physician clinical judgment, that there were not necessarily clinical decision tools that were in place, but it was more based on physician judgment. There are some practices that people, there are 3 practices that did cite some processes to facilitate the referrals. And in one case, and I'm not going to call on anybody today, but just to give you some feedback about your colleagues here on the call, there is a registry that is being used by one of the providers where the nurse coaches actually have a registry that they use to follow up. There's also a practice that has pop-ups on their EMR based on the chief complaint that depression is the primary presenting symptom. There is a pop-up that they have for that. And then yet another site has care coordinators at each site to help facilitate those referrals, and in some cases have means of maintaining that referral network. Let's go on to the next. And in terms of what referral resources, this is where it actually broke down fairly differently based on the size of the organization. And not surprisingly, most of the medium and large care systems had internal resources for behavioral health, and that makes a huge difference. Some of the larger systems did report having a fairly strong network, that they had access to patients when they identified a patient with additional needs, and that they could get those patients in and seen in a timely way. There are some that reported that they have limited access. They have some internal resources, but it's relatively limited, and the balance are somewhere in between. So I think that the bottom line for that is that areas of opportunity with a fair amount of variation. The smaller clinics, there was more consistency in that. There are a few behavioral health, there are a few that actually have internal behavioral health providers, and since they are a smaller clinic with smaller access, they have access, but it is limited. There are a couple that have really strong telehealth relationships that they've built, but I think on the smaller clinic side, some concerns about making sure that we have access to appropriate referrals at the time of need. So this is where we get into the interactive part. So we're going to put up in just a minute a polling question for you. But we're interested from your perspective, what is the most important resource need that would enable your practice to improve screening? And so we've talked to a high level of some of the things that we're hearing about: consistency with the community measurement publicly reported measure, the use of the EMR technology, coding, billing, technology issues, clinical support, access to referral resources. So let's have the operator put up the poll, and if I could ask you, I think it would be helpful for us to just get a sense from you as a group. What do you consider to be the most important resource that is going to help you move further faster? So let's take a minute to have each of you just respond. Jennifer, can you check to see if we're ready to close this?
We have 2 in progress.
Great, thank you. Okay, well, are we ready to close?
10 seconds for answers.
Okay. Looks like clinical support of the respondents' clinical support is fairly high, as is the use of the EMR technology, and followed up by access to referral resources. Okay, that sounds like about what we heard, so thank you. Let's move on to the next. So the next area that we wanted to talk about today is, as we noted at the top, every improvement effort needs to be able to demonstrate that we're making a difference. And CMS has given us a metric that they would like for us to report that would demonstrate our improvement, and we wanted to talk through what those options are. So please go to the next. So the CMS goal for the ambulatory side of this initiative is they are looking to have us increase the rate of screening for Medicare fee-for-service patients to 25% by the end of this year, 50% by the end of next year, and 75% by the end of 2018. They are giving us some flexibility in how we demonstrate that. So we've got what we call the three options, but there are numerous options. The first option is CMS standard measure, which is based on Part B claims. We also are interested in exploring with you today the ability to capture the number of screens that are performed through your EMR. And then there is always the third option, which if neither of the first two will work for your clinic, would be something that could be developed internally at your own clinic. Let's go to the next slide. So what is the current rate? And again, this is based on Part B claims, and as we noted before, we're really seeing that the volume of claims that are submitted aren't really representative of what we understand the current rate of screening to be in the clinic. So this is based on the baseline information that we had available through the Medicare fee-for-service plan. So using a baseline period of July 2014 through June of last year, there were nearly 1 million unique member or beneficiary preventive visits. So we're using as the denominator for this measure about 1 million unique opportunities where there could have been a screen performed. And the number of paid claims for either a depression or substance abuse screen for those same providers in Minnesota was 395, which would give us a rate less than 1% of beneficiaries being screened. And as we said, we know that that's not really reflective. There are screens that are performed during wellness visits, and CMS will allow us to add those as well, and there were about 11,000 screens for these same beneficiaries during that period. So ultimately would bring the rate up to 11%, but clearly if we need to get to 25% by the end of the year, what currently is happening under the Part B claims will not help us get there. Was there a comment that somebody wanted to make to that? Just wanted to not speak over people. Okay. Well, let's keep going on and looking at what the measure actually is. So this is what we're calling the CMS standard measure, and how they've defined this is they're looking at the number of fee-for-service beneficiaries receiving a screen over the number of fee-for-service beneficiaries who have a primary care visit during the reporting period. And how they define a screen is a paid claim for the codes that are listed here. And they define the visits as a paid visit for primary care. So considerations if we use the Part B claims for reporting is the good part of this is that Stratis Health does have access to reported Part B claims, and so we are able to help do those reports, or actually we are able to do that reporting for you based on what is submitted. There are going to be some limitations based on the type of clinic or organizational priority. So one of the things that we've heard, and certainly also know, is that rural health clinics don't use Part B claims, so that's not going to be an option for them. And there are other organizations who have been very strategic and very deliberate about saying, we're in the process of building our value-based contracts. We're not interested in building that kind of granular billing process for codes at that level. So in that case, there would need to be an alternative explored. There also are some technical questions about the billing, and I know that as we talk to each of you that there was some ambiguity about knowing what the criteria are. We've done some work on that. We're also currently working with both the other states in our Lake Superior which is Wisconsin and Michigan, as well as CMS, to better define that. And earlier I noticed that part of the standard measure is paid claims. And so just as an example of one of the technical issues that we want to address, and because we want to make sure that this measure can be sensitive and reflective of the work that you're doing, is that CMS currently has defined this measure as being paid claims only, which means that since this is an annual benefit and only the first incident of a screen could be paid, subsequent screening would not be counted as a compliant measure. And so we don't have a way to deduplicate this across providers so that in the case, and I don't think this would be too far out, that in the case where a patient or a beneficiary is seen by one provider and gets a screen and is billed for that, somebody in our initiative here could be doing a lot of work to make sure that's happening even as frequently as monthly, but since it had already been paid to another provider earlier in the year, it wouldn't be counted as a compliant record for the second provider. So certainly some issues that we still need to resolve. We're committed to working on that. And I think as are many people, we're just trying to raise those issues up. So there's some good use for this. It certainly has an opportunity to increase revenue. And the benefit of having that be reportable by us is there, but some things that we still need to work through. Questions or additional comments that people have about the Part B claims before we move on? Okay. Let's go on and talk a little bit about the alternative data collection then. I'm going to talk about it at a in general terms, and Laura will dig down into this a little bit more deeply. But CMS has agreed to providing flexibility in the measure. There's a couple pieces that they want us to maintain stable with the standard, and that is that they're looking to have us use as the denominator definition a unique fee-for-service beneficiary. And on the numerator side, it is the number of beneficiary screens. So those are kind of parallel data elements to the standard that we need to use. But how we go about that is part of where we have some flexibility. If we go this route, the data CMS is asking for the data to be reported on a quarterly basis. And as I mentioned, we've drafted a proposed measure, but there isn't any requirement to use what we're proposing at all. We're actually working to have this be an option for you and having it reviewed so that it has as much robustness as possible, but it really is just an option that we're presenting. And so considerations in using the alternative is if the EHR is used, it probably is likely to require additional programming changes or report development. I understand that quite a few of you do use your EMR to track some of the community measurement measures, but in order to get, for example, being able to filter out and get down to Medicare fee-for-service, that is likely to require some changes. And depending on the extent of those changes, there may be some lead time that we need to consider. I've heard from at least one provider that they make annual changes to their EMR, and typically in the fall. And so just being aware of that and being planful and moving it forward. And I do want to also note that we've got some IT resources within Stratis that are interested and available and working with us to problem solve and possibly work with the software vendors to help make that reporting work. So potentially we could do something with a specific vendor and reach out as a group to ask that provider or that vendor to help us with some of the reporting. So that's one of the considerations. And let me stop there again and just give kind of in a general opportunity for people to ask questions. Is this making sense? the standard versus the alternative? Are there concerns, questions, comments that people have about the general direction that we're taking here? Okay, well, let's dig down into the specifics on the alternative measure, and perhaps there will be some comments there.
Wonderful. Well, this is Laura, and I will get down here into the weeds on what our proposed alternative data measure would be. So this would be option B. Option C, again, would be clinic defined. So this is our proposed measure to try and have some continuity across clinics if you so choose to use this alternative data measure. One of the benefits to this is specifically you can use this type of measure to benchmark with other providers. So both the Part B, option A, and this alternative data measure would be consistent, something that can be benchmarked and compared. Clinic data may not be quite as much, so some more pros and cons. We've gone over this measure with some experts and providers, hoping to get maybe some of your feedback on this as well as we finalize what the measure itself will be. And again, it's not required. The next slide. So overall, as Jane mentioned, that there's two measures, and one is on depression screening and one is on alcohol use screening. Generally speaking, these comments here apply to all of those measures, or to both of those measures. So overall, the measures would be calculated at the clinic location level. There would be the ability, given how we'll collect this or hope to collect this from you, that we could roll this up to a system level, or that we could even drill it down to a team level or something at a lower level than a clinic. So the measure itself is calculated at the clinic level. You can see how your clinic is doing, but it's possible to do more with that than just the clinic itself. At this point in time, there aren't any exclusions by diagnosis or otherwise, and I know for some of your Minnesota community measures and many others, there are exclusions. The main reasoning for this is that we're looking at screening overall for your clinic, so it's not necessarily specific to patients. There may be some instances where you may not want to be screening, but as we're looking at this as a larger level, we think this gets at the integrity of the measure and also makes it more manageable for you to collect. This does include all Medicare fee-for-service beneficiaries, both of these measures. And again, as Jane mentioned, it would be collected and submitted on a quarterly basis. In the denominator, once again, unique Medicare fee-for-service beneficiaries seen at that location for a primary care visit during the quarterly time frame. The numerator is screening, but how we're capturing that with this alternative data collection draft measure would be the number of screens recorded specifically in the EMR. Only one screen would be counted if for some reason an individual was screened multiple times during a time period, but we're hoping to be able to pull this out of the clinic EMR documentation. So next slide. So specifically, as I mentioned, there would be two measures, alcohol use screening and depression screening. The alcohol use screening is the total number recorded in the EMR, and we're looking for pulling this out based on validated tool results. So this may be audit C. Depending on what you're using, we probably compile a list of what this entails, but we'd be looking at the number of results recorded in the EMR. And I think the depression measure slide dropped out, but this is similar. It would be PHQ-2, PHQ-9, or other tool results specific to depression. So that's your numerator for this alternative measure. And I don't know if we have fully the correct people on this team to be able to identify if these are the right data elements, on this call, but this is just a snapshot of what we would be looking to pull out of the EMR to be able to calculate this. Clinic name, location, some sort of a patient identifier, and then just flags, yes or no, for if these visits are recorded in the EMR. What we would do is develop a data form for what this looks like and work through how we get this out and submit it in a process for you to get this to us. There would also potentially be some other possibilities besides these required data elements that we could pull out if you're interested in a greater level of granularity. So I rolled through that. We're curious for one more polling question here. Based on, and this is high level, we realize, but based on what you've heard thus far. So the Part B claims, which would be your clinic submitting Part B billing claims for the screenings that have been done. The EHR, which would be the alternative data submission, or clinic-specific, which is your own definition. We're curious, just based on what you've heard today, what you think maybe is the likeliest direction you'd like to take. And the poll is up in the sidebar on your screen. If you could take a moment to select what you choose, we'll compile those results and see what it looks like. All right, looks like the poll has closed and results are popped up. We have a few people with no answer. So it looks like overall, most are thinking the alternative data and some are thinking Part B. We'll think what the no answer might be. If anyone has any comments on what they're thinking or why, that would be useful at this point. But overall, it looks like the first two options are what people are thinking at this point in time. Next slide. So next steps along these lines, we can have some follow-up conversations if there's specific questions as you sit through this and think about what you'd prefer. But we're hoping that you could send us a decision on what approach you'd like to take by August 15th. So a few weeks to think through this. If Part B claims are what you'd like to use, we'll send you some supporting documentation and some resources for how you might start doing that, and we can work with you to get that going. But if you choose that, we hope to begin billing as soon as possible. Begin recording what you're doing and getting credit for that in a good way.
Thanks.
If you're choosing to do the option B, which would be the alternative data with the EHR, we'd like to work with you to get things set up so that you can pull your first sample of data by October 1st using whatever data is available. And we'll work through some of the kinks of that, and again, we'll provide some support there. If you're choosing option 3, which would be clinic-specific, I know we had one person who indicated that might be likely, please let us know as well by August 15th, and we'll work with you to get that set up and rolling as well. We will be working on finalizing the measure and developing a protocol for how you'll submit if you choose one of the other options, so watch for that. But we wanted to get your thoughts and send this out for some feedback. We'll pause. Any questions on what you're seeing so far with measure options or comments across the board?
Hi, I'm wondering, what if you're an ACO and you're already submitting all this data already through claims and through reporting?
If it's submitted through, do you know if you're submitting it through Part B claims when you say an ACO?
Well, it's all submitted, your quality measures and screening is one of them. It's submitted through another, everybody's different, but they submit this data regardless of how it is done.
Okay. You know, we'd love to talk that through with you. My sense is that we can certainly find a way to have that be a clinic-specific approach, that if it's not part of the Part B submitted claims and it's another way of reporting, and the data elements are there that basically would allow us to drill down to Medicare beneficiaries and screens, that sounds like exactly what we need. So I think that can work. We just would need to look at the details on that a little bit.
It would certainly save time so you don't have to submit it more than once.
Yep, definitely.
Yeah, definitely.
If you're willing to just send us a note that that's what you prefer to do, we can work with you to explore that and make sure that would work for this as well.
You know, I'm interested with the majority of clinics saying that they're thinking about going forward with the EMR. Just interested in kind of the current state that you feel like you are in terms of being able to do reporting. Do you use a capability for community measurement that will allow you to to capture the information that Laura is talking about, or how much development are you anticipating would be needed in order to be able to report something like this? Or maybe that's a question that is better, we can do that one-on-one. I think if folks on the call aren't familiar with what would need to be changed in order to do this reporting, I don't want to put you on the spot, but just interested if you had thoughts about if it's a small amount of change or a large amount of change, if you had any sense of how you're currently using the EMR to be able to do reporting.
I have one question. I noticed one of the data elements was visit sequence. How would that be defined?
So the thought with that one was if you're pulling the data by quarter, and maybe I don't think this is likely to be common, but if a patient has several visits within the quarter, it would be what their first visit was, their second visit, or their third. And the reason being for that is so that we don't double count patients if for some reason they're getting screened. That's something that would be up for conversation if that's something that, based on how your EMR works, doesn't make sense or isn't feasible. But the intent of that was to capture multiple visits within a given time period so that double counting doesn't happen. So it would just be a number, 1, 2, 3.
I have a question regarding that time period of reporting, because we screen patients at least every 12 months. So if you're looking at a quarterly reporting period, they may not be screened within that quarter because they've already been screened sometime in the previous 12 months.
So the measure itself, at least the evaluation measure and the goals that we're trying to reach are actually a 12-month period. So when we're looking overall, you will get credit if someone is screened within the 12-month period. But the quarterly is just to get data at a more frequent amount of time. So if a patient is not in the office, they won't be in the denominator for that quarter. It won't look bad on your rates. It will still show you where you're at. But I guess
so we have a 12-month look back.
Yep, 12-month look back, just quarterly submission to have the process be a little more frequent.
So the denominator is defined on a quarterly basis, but any look back for the numerator is still over the 12 months.
Correct. Yep.
So it would only be patients who have been seen in the clinic during that quarter.
Exactly, yeah.
Okay.
Sorry, I did not make that very clear.
No, you made it very clear. I just wanted to say it a different way in case that means for somebody.
Definitely. This measure is not completely finalized as well, so if in the meantime between now and August 15th, and preferably sooner so we can be finalizing it, but if you have feedback on what might make it more robust or easier to pull out of an EMR, we'd love your feedback as well.
One other comment I had about the alcohol, we had done a project already on the audit, and we used that as a secondary screening, and we used a one question as a primary screening. So that'd be just something to consider.
Okay.
I like that idea too. We've done that at Fairview, looking at even expert in the past, where the NIAAA was the one question, and then if that was positive, we'd go on to the audit.
I know that the way that the CMS measure works is that they're actually asking us to define that based on an evidence-based tool, and when people use PHQ-2s and then move to the PHQ-9 based on the results of the smaller referral or the smaller assessment, that actually works. I'm assuming, and I don't know this as I sit here today, that if there's a one question that NIAAA measure, then prompts for the more complete audit tool. I'm expecting that would work, but that is something that we'll need to kind of drill down and make sure that that parallel process works on the alcohol side as well. Has anybody else investigated that? Are you aware that kind of that two-step process, if that works for other reporting?
We had looked at that at Fairview with regard to an expert grant, and DHS the Alcohol and Drug Abuse Division had given approval to do that.
Okay. That's good to know. Thank you.
And we had a very similar experience. The one comment I will also add is we have Epic as our EHR, and they have an Epic delivered section on alcohol use, which I do not believe is evidence-based, but that would be great if Epic used an Epic delivered evidence-based alcohol screening tool. So.
Yeah. Good point.
So I think the question that remains for me then is just if the NIAAA would suffice for the screening reimbursement.
I think I'm not going to go out on a limb. It sounded like there's indication that could well meet that criteria as long as it's a two-step. But as I sit here today, I haven't looked into that, so I'm not sure of that. But it's something.
Thanks for looking into that. That'll be helpful.
Yeah, definitely. So good discussion. Other thoughts that people have about this measurement? You may want to look at some of the details a little bit more after the fact, and if you have additional thoughts about that, Laura is very much kind of actively working this, and we've presented it to a couple different groups, and so really want to make sure that this is, if people are going to invest the time and resources into being able to report this, that there's some validity to this as well. And actually, I'm getting a question about, can we get this webinar? Yes, absolutely. On the links that were sent out, you should have been able, I've been told that you were able to get to the slides on that, to be able to download them. If that's not the case, we will send the slides out after the fact, and I apologize if you, that I didn't ensure that you had that as we were getting started. But this webinar is also being recorded, and so if you have additional people who want to listen to this, we will make both the slides and this recording available, and it will be on the Behavioral Health Initiative website, and we'll send you out the link to that after this call.
Do you also have more detailed measurement specifications for the EHR method?
We do indeed. I didn't want to overwhelm you on the webinar, but we'll share those with you as well. It's a much more detailed table that has some specifications. We'll share that out with you after this as well.
Good. Well, thank you. Well, let's go into the next section of this webinar today. And so, kind of understanding that one of the things that we need to do is around measurements. Let's go to the next slide and have some discussion about so how do we actually move forward? We know that ultimately CMS is asking us to improve the rate of screening. And so as we've talked about today, I think how we go about demonstrating our improvement is going to be germane to the work that we do as part of this group. It's either going to involve starting to do some additional billing or setting up the EMR. So that measurement section is kind of the first part. But then as we looked at both the information we were receiving from you about what's the current environment within your clinic, and as we've reached out to other states and other initiatives to try to understand what is the window of opportunity, how do we break this initiative down into workable components. And so this is a proposal that we'd like to get your feedback on. So starting out with measurement, I think that's probably not debatable. But one of the things that we think would be useful for this group is to focus on and making sure that we're also, at the same time that we're increasing the rate of screen, that we're also keeping in mind the effectiveness of that screen. And one of the helpful discussions that I was a part of looked back at how domestic violence screening first started getting implemented into primary care. And the discussion was around when that screening first started, that both clinic staff as well as patients were not really sure, well, why are you asking me that? And there was concerns on kind of the full component about, is that really appropriate, and should I be asking and talking about that here? And it wasn't until there had been some time, and it actually sounds like it was a period of years, that became more of the accepted and an understandable part of the primary care visit. And kind of in a parallel way, one of the things that I'm hoping that we will keep in mind is that it's not just enough to be handing a patient a piece of paper in the reception area. That how do we make sure that the work that we're doing is both increasing that screening, but we're also setting up the systems to make sure that those screenings are being efficiently and effectively being done. So one of the proposals that I have for you is Claire Neely is a physician who has been part of Diamond and other initiatives in the state, and she's working with us on that. And she and I have had some discussions about a presentation that she could do about what do we need to do to set up a culture for making this a safe discussion in the clinic, or not safe, but a valued discussion in the clinics. And so that's one of the areas where I propose that we could start next. I'm also hearing some interest around motivational interviewing of how we help clinic staff that are doing the assessments be able to elicit the information out of patients. And then also one of the other things in terms of effectiveness that ultimately we may want to look at is if we look at the current rate of screening, which is focused around preventive visits, I'm not sure that we're going to get to a rate of 75% in the next 3 years. And to the degree that we're able to do that, I think we certainly need to give a good try. But one of the things that I don't think is debatable on a clinical side is that there are comorbidities with some of the chronic conditions that might be ripe for starting to have depression screens be part of those visits as well. So depression, some of the cardiac conditions, that might be something that we could have some discussion around. When do we start, or do we start, migrating the screening away from just preventive visits and starting to include it into a wider berth of visit types as well? So kind of effectiveness was one of the areas. And then based on the things that we were hearing about triaging, I think really what we're hearing is that there is never going to be a time in the state of Minnesota that we have enough psychiatrists to really be able to take on all of the mental health issues that we have. And so how do we actually how do we better triage that care within primary care, and at what point is it appropriate that we should be referring patients into specialty care? So I think one of the proposals that I would have for this group is the investigation of, are there protocols, and I know that there's at least one system now that has created some clinic decision tools around when is it appropriate for a patient to stay within primary care, and when is it appropriate for them to be referred out. But kind of the third proposal to you today is looking at that as another area that we could do some improvement around. And then last but not least, the referral networks, and how do we build the appropriate size networks so that there are resources that are available for patients. So that's a proposal. If people have comments today, that would be terrific. If you would prefer that we have one-off discussions about that, also willing to talk about that. But as we look at mapping out how we move forward from here to where we're going in the next period of time, I think we need to find a way of narrowing and focusing the topics so that we're not trying to boil the ocean, but we're really focusing on how do we make the work that we're doing as effective as possible. So let me stop there and see if people have comments or thoughts about any of these topics. Do they sound like they're helpful topics for you? Okay. Well, hearing none, we can let's keep going, and we'll talk about how we're going to structure the work that we can do together. So I mentioned that, and you've heard before, that Minnesota Stratis is working with our colleagues in both Wisconsin and Michigan, and the three different organizations comprise what is known as the Lake Superior Quality Improvement Network. And currently, the three organizations have worked together to create what is expected to be, and you'll see the cadence is a little bit off just because of some of the timing, but our expectation is that we would have every other month webinar that would be available to everybody across the three states. So there was a kickoff that occurred in February. In April, Fairview did a terrific presentation about how they're using the PHQ-2 and 9. In June, there was a presentation about the new quality measures that are specific to the inpatient psychiatric facilities. And then there also was a component, and if you didn't see this part, it might be interesting to go back. There's a provider in Milwaukee who has created some bridge appointments of when a patient is discharged from an IPF, a bridge appointment to help as they transition to the community, and it was I think a well-done presentation. And all of those are currently on the behavioral health website. Coming up, we've got a webinar that's planned for September 25th that will be on opioid use. And then on October 20th, we're planning to do a presentation on patient and family. We've got somebody prepped up who I think will be terrific on those. And if you haven't heard about the opioid use yet, you will very shortly. I think that is just being kind of the materials for that are just being finalized, but you should receive an invitation to that very soon. So that's what's happening at the regional level. Let's go to the next. So the next is more at the Minnesota level, and that's this group that we are talking to today. And what we would propose is that we would have this group get together on a kind of a schedule that is different than what the webinar is. So we could either do August or September, creating a culture for the behavioral health screens, as I spoke of. Claire Neely could do a presentation on that, and then some of the additional topics that we discussed. And we'll be polling you on topics at a later time. So that would be the Minnesota kind of the large group. And then one of the options, let's go to the next slide, is what is probably better termed as an action cohort, and I don't know if that sounds jargony as I say that, but depending on how you choose to do the evaluation measures, we're anticipating that we could do something, for example, very specifically around clinic systems that are using a specific type of EMR, and how do we work with that EMR to get the kind of reporting, and do we reach out to the vendor, and some work that would be just more germane to that group, as well as providers who are doing increased billing, and drilling down and making sure that any of the technical resources needed to do that are available. So that's a proposal that we would, if you choose and if you want us to have that as an option, that's one of the other options that we would present to you. And then lastly, at a more kind of specific level, we'll be setting up quarterly progress telephone check-ins. And that would just be an opportunity for us one-on-one to be able to hear issues that you're having and be able to provide assistance that's more specific to you. So we're going to go to the next polling question. And this question has to do with the large group discussion. So this group, if the regional calls are every other month or thereabouts, how often would you want to have this group getting together to discuss, how I would see the structure of that being is likely to have somebody kicking off a specific topic. So in this example, building culture, and then we would have both a presentation about that and an opportunity for people to share what is it that you've done around this, what are some of the questions, and have there be kind of two components to each of those discussions or to each of those meetings. Given that, how often would you like that group to meet? Would you want that to be monthly, every other month, so opposite the regional webinar, on a quarterly basis, or some other frequency? And the poll is open, and if you would check your response, that would be terrific. Okay, I think that was the time limit. Is the polling ready to present?
8 seconds.
Okay. Okay, it's like quarterly is the preferred, followed by quarterly is well preferred, every other month, and just one person was looking for monthly. So okay, that's helpful. And let's go immediately into the last polling question, another opportunity for you to help make sure that this initiative is useful and valuable to you. So if we go to the next poll, which is looking at, if you think about your work and what topics is most urgent for you in terms of how you move this forward. The topics that we discussed here is support for project management. So creating a process flow and identifying key opportunities for improvement, additional work on billing and coding specifics to make sure that that is being that you have the most accurate and up-to-date information, the use of the EMR, or EHR, skill building for staff to improve effectiveness of screens, selection of a screening tool, and mission and leadership engagement, and making sure that we've articulated a clear rationale for this initiative. So with those 6 things, if you select what is the most urgent that you have from your perspective.
Oh, people, I hate you.
Okay, it looks like the time has left. Is the poll ready to close? Okay, well, it looks like the project management and billing and coding is the preferred, and then followed by physician and leadership engagement. So, great, good, helpful information. So, thank you. Well, that is the material that we have presented to you. We will send out a link to the slides as well as the timeline, the additional information about the alternative data collection and kind of the next steps, and we'll look forward to kind of getting the next initiative or the next steps going for this initiative. So any parting or additional questions, comments that people want to make before we close? We're actually got some time to have some additional questions. Should we check the chat and just make sure that there aren't additional questions that have come in there? Okay, there is a comment about motivational interviewing interest. So definitely noted. That's great. Any parting or final thoughts? Okay. Well, we will take this information. We'll be sending it out soon, and we look forward to working with you and appreciate your time today. So thank you. Actually, before I sign off, could I just double-check a couple clinics and just make sure? Did anybody from Avera join us?
Yes.
Great. Catholic Health Initiative? Center Care?
Yes.
Terrific. Fairview?
Yes.
Okay. Hutchinson Health? Lakewood? Everyone else. Northfield Hospital? And Sleepy Eye. I think we have everybody else previously accounted for. So terrific. Thank you all again for your time. And as I said, we look forward to working with you. Thank you.
Thank you. And thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.